Hello, this is Dr. Amin Marashi, retina specialist from Aleppo, Syria. This course is about clinical changes in RPE. This presentation is about PED in non-AMD cases. PED can be presented in non-AMD most commonly in polypoidal choroidal vasculopathy, central serous retinopathy, acute or chronic. Polypoidal choroidal vasculopathy (PCV) is a choroidal vascular disease that causes RPE detachment with mixed serum and blood, which may lead to subretinal fibrosis. On clinical examination, polypoidal choroidal vasculopathy appears as reddish-orange, round and punched from the choroid into the subretinal area, and with or without subretinal fluids, blood, subretinal exudates, and sometimes hard drusen. On OCT, polypoidal choroidal vasculopathy appears as M-shaped or dome-shaped elevation of RPE with visible choroidal polyps, will adhere to RPE, which may have clear fluid or hemorrhage beneath it, with prominent Brooks membrane, forming double-layered sign in the absence of blood, along with subretinal fluid and less commonly intraretinal cysts formation, and thus may explain better visual prognosis in some cases. Although ICG is the gold standard to diagnose polypoidal choroidal vasculopathy, fluorescein angiogram shows hyperfluorescence may look similar to fibrovascular PED with hyperfluorescence notch, resembling polyps surrounding with subretinal dye pooling and may be combined with RPE atrophy inducing window defect. In early phase, angiogram shows hyperfluorescence from polypoidal choroidal vasculopathy, which is increased in mid-phase, along with hyperfluorescence from PED. Late phase angiogram shows leakage from polypoidal choroidal vasculopathy, sub-RPE dye pooling, and subretinal dye pooling. The prognosis of polypoidal choroidal vasculopathy depends on the involved area and responds better to VEGF trap agents, such as aflibercept and compercept, and may require half-dose PDT in recalcitrant cases. Acute central serous retinopathy (CSR) is a serous retinal detachment caused by increased choroidal permeability and RPE dysfunction leading to subacute visual loss. On clinical examination, it may feature PED, which appears as a yellowish rounded elevation of RPE beneath or adjacent to subretinal fluid, but not all CSR cases associated with PED. On OCT, it shows central subretinal fluid with PED and visible Brooks membrane featuring double-layered sign, along with elongation of photoreceptors outer segment, and increased the thickness of choroidal and dilated hilars. Fluorescein angiogram in early phase shows hyperfluorescence from PED, which increases in mid-phase, in addition to hyperfluorescence of subretinal fluid leak, where late phase shows smokestack or hotspot leakage, dye pooling from sub-RPE, and dye pooling from subretinal fluids. Chronic CSR appears as granular RPE changes, along with subretinal fluid and PED. On OCT, shows central subretinal fluid with PED and granular RPE changes, along with elongation of photoreceptors outer segment and increased thickness of the choroid and the dilated hilars. Fluorescein angiogram in early phase shows hyperfluorescence from granular RPE changes and PED, which increase and become more prominent in mid-phase, where in late phase shows granular hyperfluorescence, dye pooling sub-RPE, and dye pooling from subretinal fluids. The prognosis of CSR is good if it didn't complicate into choroidal neovascular membrane. Some cases does not warrant treatment and may resolve spontaneously, and treatment options include iloperidone 25 mg a day or spironolactone 25 mg a day. However, potassium levels and liver enzymes levels should be monitored under the supervision of internist. Another oral treatment option is rifampicin 300 mg a day or subthreshold laser However, half-dose PTT can be used in chronic recalcitrant cases. Intravitreal anti-VEGF can be used only if there is choroidal neovascular membrane. Please stay tuned for my next presentation about RPE rape and atrophic RPE changes. I hope you find this information beneficial in your clinical practice. Thank you for listening.